Hypospadias, congenital, the urethral meatus on the ventral or underside of the penis. The meatus can be anywhere on the shaft. It's the most common anomaly of the penis. Penile chordy, which is a shortage of the skin on the vertebral surface, which causes the penis to bend or to bow ventrally. Penile torsion is a counterclockwise rotation of the penile shaft. Risk factors: genetic, endocrine, environmental, advanced maternal age, low birth weight, and then the penile torsion and chordy. Treatment is surgical. It's to straighten the penis, make it uniform, make the urethra uniform so that it can prevent sprain when they're going to the bathroom, to give it a good cosmetic appearance. And surgery is generally done within 6 and 12 months of age. Epispadias. The dorsal urethra is not fused. It failed to form the tube. The male urethral opening is small and generally behind the glans penis. Fissures may extend the length of the penis into the bladder neck. Females, a cleft along the ventricle urethra to the bladder neck. Distal aspadias leads to 75% incontinence rate. Pediatric cancers or tumors. Nephroblastoma, or also called a Wilms tumor, it's rare. It's an embryonic tumor of the kidney. It peaks between 2 to 3 years. There's many congenital issues. Bilateral tumors are rare. METS is usually regional lymph nodes in the lungs and less common to the liver, brain, and bone. Risk factors: it's increased in black children, WT1, WT2 gene mutations, antiviral, partial or complete missing iris, not antiviral, and aniridia. That's a partial or complete missing of the iris. Hemihyperplasia, a horseshoe kidney. Hypospadias, urethral duplication, polycystic kidney. Pathogenesis: undifferentiated mesoderm, mutation of several tumor suppressing genes. Clinical manifestations: enlarging asymptomatic abdominal mass before age 5, vague abdominal pain, hematuria, anemia and fever, hypertension. This is due to the increased renin secretion from the tumor. Those with long-term survival have an increased risk of heart failure, renal failure, and hypertension. Diagnosis is there's a firm non-tender tumor confined to one side, diagnostic imaging and biopsy. Treatment: surgical exploration, resection, including nephron-sparing surgery, chemotherapy, radiation therapy in children with a higher stage of the disease and or METS. Biliary atresia. It's a rare congenital malformation. It's an absence or obstruction of extrahepatic bile duct. It causes neonatal cholecystitis, atresia of bile duct, inflammation, fibrosis, loss of epithelial cells, obstruction in the bile canaliculi, secondary biliary cirrhosis, portal hypertension, liver failure, fat absorption is impaired. Pathogenesis: it's embryonic or congenital abnormality or an acquired abnormality. Clinical manifestations: jaundice, hepatomegaly, clay-colored stools, abdominal distension, and that's from the hepatomegaly and ascites, anorexia, faltering growth, fat-soluble vitamin deficiency. It could cause a possible coma, so this would be your D, your E, and your K. And remember, that's because the fat absorption is impaired. And manifestations of cirrhosis. Pyloric stenosis. It's a narrowing and distal obstruction of the pylorus, most common cause of intestinal obstruction in infancy. The muscle fibers thicken, folding and narrowing of the pyloric sphincter muscle. Increased force to push gastric contents can cause hypertrophy of the stomach muscles. The etiology is unknown. Clinical manifestations: postprandial vomiting, and then the child becomes very hungry afterwards. So a normal infant will suddenly start forceful projectile vomiting and then demands refeeding. Constipation. So in severe cases, you could have gastric peristalsis. So vomiting leads to dehydration, weight loss, shock, may have blood in the emesis, and the infants are very irritable. Diagnosis is with ultrasound. The pylorus is palpable as firm. It's the size of an olive and felt in the upper right quadrant in 70 to 90%, and the ultrasound shows a narrow pyloric channel. Treatment is laparoscopic pyloamyotomy. So basically the muscles are split and separated, and then correct fluid and electrolyte imbalances. Intussusception. So it's a telescoping of the proximal segment of the intestine into the distal segment. It causes obstruction. The ileum telescopes into the cecum. Proximal intestine telescope into the distal intestine in the direction of peristaltic flow. Risk factors: they're usually between 5 and 7 months of age. It's increased in males: polyps, tumors, cystic fibrosis, Meckel diverticulum, interstitial adhesions, abdominal surgery. Rotavirus vaccine is a very small risk. Clinical manifestations: venous stasis, engorgement, edema, vascular compression, and flow obstruction. Diagnosed with an ultrasound or an x-ray. The treatment is an enema reduction for the large bowel and laparotomy for the small bowel. After reduction, recovery is within 24 hours. Left untreated, it is fatal. Diverticula. Herniation or a sac-like outpoaching. It's usually in the wall of the sigmoid. It's rare to the small intestine. Diverticulosis is the asymptomatic disease state. Diverticulitis is the inflammatory state. It can occur anywhere. It's usually usually in the colon. I can't read my own writing, it's so small. Increased collagen and elastin deposits, muscle thickening, law of Lapille. Risk factors: increase ketonic pressure, abdomen muscular function is impaired. A herniation in the GI motility, increased age, genetics, obesity, smoking, decreased physical exercise, aspirin, NSAIDs, decreased fiber, visceral hypersensitivity, abnormal colonic motility. It can be from altered intestinal microbiota. It causes increased intra-abdominal pressure. Severe complications would be abscess, fistula, bleeding, or obstruction. Clinical manifestations: abdominal cramping, diarrhea, constipation, distension, flatulence. Diagnosis: fever, leukocytosis, ultrasound, sigmoidoscopy, colonoscopy, CT. Treatment is increased fiber, bowel rest, clear liquid diet, analgesia. Antibiotics, probiotics, 5-amoxicillic acid, and a laparoscopic resection. Incontinence, LUT, structural or anatomic disorder, affects capacity and storage, affects emptying, urge, stress, overflow, or functional or mixed. Detrusor hyperflexion is a neurological disease. Detrusor instability is non-neuro. Men get stress incontinence after prostate surgery. Mixed is generally with older adults. It's not considered a normal part of aging, and it can usually be fixed. Risk factors: increased in women, increased age, increased or enlarged prostate, lesions or obstructions in both males and females. Treatment is lifestyle adaptation, behavioral, there's some medication. PCOS, the most common endocrine disorder affecting females. Inappropriate gonadotropin secretion, low FSH, increased LH. The increased LH stimulates increased estrogen, a 3 times greater risk for uterine cancer. Risk factors are female, obesity, genetics, insulin resistance, increased insulin, increased androgen. It's a disease of inheritability. Clinical manifestations: irregular ovulation, increased levels of androgens, polycystic ovary, is noted on ultrasound. You have to have 2 of those 3. So 2 of either the irregular ovulation, increased levels of androgen, and polycystic ovaries noted on ultrasound. You have to have 2 of those 3 for a diagnosis. Infertility, obesity: 60% of people with PCOS are obese. Increased insulin, hair follicle growth. That's impaired from the free testosterone floating around. Menstrual irregularities, hirsutism, acne, and acanthosis nigricans, hypertension, dyslipidemia, and sleep apnea. Diagnosis: 2 of the 3, and then it's also a diagnosis of exclusion. Treatment is oral contraceptives, lifestyle modification, weight loss, and metformin or progesterone.